but we're going to go ahead and get started. And so hopefully by the time we do introductions, it'll be enough time for all folks to join us this morning. So first, I just wanted to welcome you all to today's conversation. As you may know, this is our first in a three-part series about opioids and the workplace. And I'll share more about what prompted this series and some of the other opportunities for you all to engage in this really important topic. So in 2019, before the pandemic, partners in Buffalo recognized a growing prevalence of opioids and their impact in workplaces. Unfortunately, we saw the pandemic exacerbate this issue. So as we've seen, opioids have been in the headline for decades regarding the devastation they've caused to individuals, lives, families, communities here in Buffalo and across the US. But the role of workplaces in this epidemic has been really largely ignored. Whether through workplace exposures or injuries, work has been a significant contributor to the waves of this opioid epidemic. So the Western New York Council on Occupational Safety and Health, WNCOSH, ECMC Clinic on Occupational Environmental Medicine, and the Cornell ILR Buffalo CoLab, Cornell University, are teaming up today and in the next 6 weeks to offer a series of workshops for community members here in Buffalo locally, but also nationally, to provide resources, data, information, and tools to help. As I said, today is our first in a three-part series, and we'll hear from two speakers. The first is Nellie Brown, a certified industrial hygienist and director of workplace health and safety programs for Cornell ILR University, and she'll be sharing why opioids are a workplace issue. Next, we'll hear from Cheryll Moore, the ECDOH opioid program director, on the extent of this epidemic. So that's our conversation today, but I just wanted to note two more opportunities for you all to engage. On Thursday, February 16th, there'll be another webinar from 10 to 12, and I'll put the resources and information in a follow-up email, and I'll provide it in the chat. And we'll talk about opioids and workers' compensation, workplace policies on prescription drug use, opioids, and mental health concerns. And we'll hear from Dr. Singh and Dr. Sananthal, each from ECMC and Cornell ILR respectively. The final workshop is actually training on Narcan. So we'll provide a free training, overdose recognition tips, Narcan administration, and access to kits. This will actually be in person. So as we've mentioned, you don't have to sign up for every single one of these workshops, but you're welcome to sign up for any ones that you're able to attend. Before I pass it off, I just wanted to note a few things. We may be more familiar with webinars than we had been in the last 3 or so years, but we're recording this webinar and we'll send it out to attendees afterwards. There's a Q&A option at the bottom of Zoom where you can regularly ask questions that'll appear publicly throughout our workshop today. The way that we've set this up is that we'll hear from Nellie Brown for about 45 minutes and then open it up for about 15 minutes of questions. And then we'll hear from Cheryll Moore for about 45 minutes and open it up for 15 minutes of questions. But you're welcome to ask questions regularly throughout the conversation today. And we'll be able to lift those up to our speakers if they're timely. Again, we'll be sending these resources and information afterwards. So without further ado, I'm going to pass it off to Nellie Brown. Thank you.
Hey, thank you, Cricky. So now I will share my screen here. And start my PowerPoint. Okay. So, okay. So I'm going to kick off today's program by looking at opioids from the standpoint of why would they be a workplace problem. So I'm going to talk a bit about occupations that have been seen to be at risk for opioid exposure, as well as occupations at risk for opioid use and, of course, potential abuse as well. And then we'll take a look at some control measures that would be available to address exposures in the workplace using the approach of the hierarchy of controls. So I'll talk a little bit more about that when I reach that point. So how might workplace exposure occur for opioids? Well, of course, it can be simply that people are handling opioids as part of their job, and they're getting exposure through either their routine handling of these as medications or through an accidental exposure or something in the handling process should go wrong. So this could be, of course, in the care of people, such as the use of opioids by doctors, dentists, pharmacists, nurses, home health care aides, anyone handling this. And keep in mind that in those facilities, the people who do a cleanup could be exposed as well. We also have opioid handling in those whose occupations involve the care of animals, and that includes veterinarians and zoo employees, as well as people who respond to wild animals in the environment, which can be, for example, there is a bear along the 990, which happened not too long ago. And this typically is an issue that is referred to our New York State Department of Environmental Conservation staff. Now, another issue for workplace exposure, of course, is where people would have exposure because they're dealing with the aftermath of an opioid overdose or they're addressing a crime scene. And that could include people whose jobs involve being first responders, EMTs, of course, some of which are firefighters, of course. It could be, of course, police, forensic technicians, forensic laboratory workers, as well as, again, people who are cleaning up these sites after an overdose has occurred or after a crime scene has been, finished in terms of its police and forensic work. So why might this be a problem otherwise in workplaces? Well, sometimes what happens is that people experience an occupational injury or illness leading to pain. And in this case, we are seeing quite a number of different occupations facing this particular risk problem. It can arise from ergonomic issues, people doing lifting, handling, carrying, all kinds of physical demands in the body, and they end up with sprains, strains, injuries of various kinds, and they are relying on opioids to address the pain. We also are seeing people draw on opioids who are dealing with jobs that have considerably high stress levels associated with them. And at the same time, when people experience high stress in a job, it's very typically characterized by the job having high demands, but people have low control over how they do the job or use their time or resources or how they do decision-making in their workplace. And people are using opioids to deal with that stress. Keep in mind that for many people, self-treatment with opioids can lead to further vulnerability to work-related injury or, of course, to overdose deaths. And a lot of people who are using opioids to address workplace pressures and injuries are often themselves feeling a lot of pressure to return to work. They may not have guaranteed sick time or may be pressured not to use it. We may have people whose fear of job loss, the very nature of their jobs, they're insecure. And we also have people who simply want to treat the pain and move on. And they may not even be reporting their injuries because they simply don't want to address that aspect of the problem in the workplace. They want to simply get on with their jobs. Now, when it comes to opioids in the workplace, I'd like to make a distinction here between legal use and illegal use. Keep in mind that people who are using opioids legally in the workplace are protected under federal disability law, and they can, in fact, request an accommodation under the Americans with Disabilities Act, or ADA, if, for example, their use of opioids might in some way create a safety issue. So under the ADA, the employer has to look at this issue and consider if there is indeed a way for you to be able to do the job safely and effectively. Now, if an employee is in fact taking an opioid medicine as directed in a medication-assisted program, they cannot be denied a job or fired unless, as the law states, you cannot do the job safely and effectively, or you're disqualified under another federal law. Now, keep in mind, the Americans with Disabilities Act does allow employers to fire an employee for opioids illegal use, even if that illegal use is not constituting some type of performance or safety problem in the workplace. So I like to ask the question, what about your workplace? Does it have a workplace supported recovery program to assist workers with opioid and substance use disorder issues? And if you're interested in that particular topic, do come back and attend our webinar on February 16th, where Dr. Sonnenstall will address that concern. So let's take a look at some of these issues in a little more detail and really open this up a bit more. When we talk about occupations at risk for opioid use and abuse, I'd like to note for you that there have been, in fact, studies of this to take a look at who seems to be most affected. Well, it turns out a lot of the ergonomic issues are, of course, appearing in the construction trades and among nursing aides doing patient removal. A lot of the pressures of stress and job insecurity are often occurring among food preparation workers. We often find opioid issues beginning to emerge where people have easy access to opioids at work in the course of their job, such as those working in healthcare or pharmacy or in veterinary clinics. One of the things that has been noted by veterinarians is that they have reported that pet owners will often abuse their pets' leftover opioids, or even intentionally make an animal ill, injure an animal, or make an animal seem ill or injured in order to obtain opioid medications, which they can then use themselves. Now, when you look at occupational studies of the opioid issue, looking through this lens from our National Survey of Drug Use and Health, we have seen the misuse of prescription opioids appear in higher levels among, for example, construction workers compared to workers in all other professions. Again, reflecting how people are dealing with ergonomic injury or often trying to simply work through the pain. And this same survey points out uses in construction, for example, of cocaine as well, or in the cases of cannabis, in other words, marijuana, we're seeing a lot of that in construction and service industries too. Now, one of the things that has come together in the last few years is the overlap between the COVID-19 pandemic and the opioid overdose epidemic. It seems the two converging have created really a perfect storm for increasing the opioid problem. We are seeing that our intent to prevent the spread of communicable disease led to our use of lockdowns. We have seen more people experiencing, as a result, the isolation of lockdown, experiencing the grief of dealing with this pandemic, of losing loved ones or dealing with the disease and illnesses themselves and their families and friends. And we have seen, because of this isolation, the fraying of our social networks, and these things have put a lot of pressure on people. We've seen, as a result, a rise in mental health disorders like anxiety and depression, because we're social animals, and this has been very difficult. The pandemic has also been very hard on many industries and occupations in which job loss has become quite dramatic, and people experiencing despair from job loss. All of these become a lot of pressures for people to experience. Now, people struggling with already addiction or in recovery are indeed prone to relapse. And unfortunately, the stress and isolation of the COVID-19 pandemic has meant people have had fewer places to turn to for assistance with their opioid problem. Healthcare providers nationwide have struggled to address the huge numbers of coronavirus patients. And because of the need to move healthcare workers around and service people who are ill with the pandemic, we end up with treatments for issues like substance abuse have been postponed, just as treatments for other types of surgeries and treatments have been discontinued as well or postponed. We also have, on top of that, the ubiquity of access to fentanyl. And this has fueled the rise in death. It's a very fast-acting drug. In comparison to morphine, is considered to be 100 times more powerful and has sometimes been added surreptitiously to other illegally manufactured drugs, increasing the potential for serious overdose or death. A National Institutes of Health analysis found that people with opioid, cocaine, cannabis, and other use disorders were at significantly higher risk also of experiencing COVID-19 breakthrough infections. And this has been due largely to what we think socioeconomic factors, concurrent health conditions, and so forth. We've also seen something else overlap with the opioid pandemic, and that is that because opioids bring about the issue of injection drug use concerns and needle stick reuse, needle stick injury, and so on, we have seen an increase in diseases transmitted through that route. And that includes increases in both hepatitis B virus and hepatitis C virus. And in fact, these diseases have increased most dramatically in the states hardest hit by the opioid crisis. Now, keep in mind, for hepatitis B, we do have a vaccine, and we have been attempting to vaccinate even newborns for quite a number of years now. But with injection drug use and, of course, also sexual transmission, we have seen a rise in acute hepatitis B cases. With hepatitis C, the rate of acute cases here has also increased, some 2/3 of these cases appearing among people 20 to 39 years of age, which is also the age group overlapping with the opioid crisis. The CDC is now recommending that people who do inject drugs should get themselves tested regularly for hepatitis C. We again have medications, and we can do a lot for this disease too. Now, a workplace exposure, of course, could occur at an opioid processing site, illegal, of course, or at a site of overdose. So in looking at risk assessment for this, we pay attention to what is going on at these locations. What is the form of the opioid that might lead in turn to people's exposure addressing these sites? Is it in the form of a powder, which could be more easily airborne? Is it instead in the form of tablets, pills, or rocks, which are less likely, of course, to be airborne? Is the material at full strength? Has it been cut with other agents such as lactose or mannitol? And what sort of equipment is present that itself can contribute to the exposure or which needs to be containerized or in turn decontaminated, such as milling equipment or pill presses? So let's think about this as an occupational exposure situation. How might people become exposed to opioids? Well, even people, of course, handling drugs in pharmacy and veterinary care and so forth, we always have to be aware of what our routes of entry might be. Well, keep in mind, we have the route of entry of inhalation with airborne particles. Remember, with airborne particles, their size determines how far into the lungs they'll go. And we'll explore this in a little more detail in a moment. Obviously, the smaller the particle, the deeper into the lung the airstream can be carried as we inhale. Keep in mind that very tiny particles can end up in the air sacs. If the material is water soluble, the item will then dissolve and can rapidly enter the bloodstream. So inhalation is indeed considered a very significant route of exposure. Now, what about the route of entry of direct contact of this material with the skin or eyes? Keep in mind, airborne particles can get into the eyes or land on the skin. Or, of course, they can land on surfaces, and we in turn might touch those contaminated surfaces and in turn transfer the material to the mucous membranes of our eyes, nose, or mouth. Now, when it comes to skin absorption, keep in mind that microscopic amounts can be accidentally absorbed, but the information we have, and it's quite extensive, indicates that the dosage absorbed through the skin is not anywhere near the quantities that could make you feel symptoms. So we don't tend to think of this as a huge route of entry. It's potential, obviously, but not a very significant one. But of course, if the skin is broken, what we call injection injury, where we have damaged skin, or of course, a percutaneous exposure, in other words, a puncture wound, such as a needle stick, then yes, direct exposure into the bloodstream is possible there. Now, what about ingestion? I know people never like to think about accidental ingestion, but when you think about particles in the air, they can land on the lips. We lick our lips, we eat what's there. We can have hand-to-mouth transfer if we've not washed our hands before eating, smoking, anytime we touch the mouth. Is it a contaminated object, which we in turn place in our mouth? People often don't even realize they're doing these things. And of course, what about contaminated fingers? Many people who have habitual nail biters, for example, don't even realize how much hand-to-mouth transfer they really have. Now, one situation that has been brought to the media's attention quite a bit is this issue of people in the police, sheriff's department, forensic workers who might have exposure in dealing with contaminated sites. Well, one such video has been very harshly criticized. This one came from the San Diego County Sheriff's Department, and it showed a trainee collapsing while investigating a substance that he believed to be fentanyl. And this has been met with a great deal of skepticism from medical and addiction experts. This case was reported in the New York Times. Now, medical experts were very concerned that this kind of video can promote a false narrative and confusion about fentanyl in ways that it could lead to an overdose. And as I was saying earlier, microscopic amounts can indeed be accidentally absorbed through the skin, but not anywhere near quantities that could make you feel symptoms, let alone overdose. The idea of overdose on contact is in fact a myth. And if you look at this issue, for example, people who are using fentanyl patches designed for skin absorption are formulated with special gels to assist the fentanyl to migrate through the skin and be absorbed. And even that takes hours to accomplish. So let's think about exposure routes. We have the issue of inhalation with airborne particles, and there have been published studies about this. Particles in the size range typical for fentanyl, which is about 1 to 3 microns, are known to settle in still air in anywhere from 1.5 hours for a 3 micron size to as long as 12 hours for very tiny particles of the 1 micron size. So yes, in still air, dusts can be airborne. Now, what about turbulent air? Particles that are 3 microns or 1 to 1 micron in size will settle eventually in turbulent air, with 3 microns taking 1.5 hours and 1 micron taking as long as 12 hours to finally settle onto surfaces. And I draw people's attention to this because if we're doing cleanup of surfaces, scrubbing those surfaces where opioids are present can produce turbulent airflow and make things more airborne. So obviously we need to be very careful with the techniques we use for cleaning up sites. And that is why I mentioned earlier in the program that even people who do cleanup need to be concerned about exposure. Now, when you think about synthetic opioid particles, say, of around 2 microns in size, keep in mind that the size distribution still is based a lot on how the material was prepared, what adulterants are present, and so on. But when we look at the inhalation of particles that are large, as they are breathed in through the nose or the mouth, they tend to impact against the back of the throat and as a result are swallowed. So when you look at these smaller particles, more typical of the synthetic opioids, you're talking about materials that were more likely to inhale deeper into the lung. When they get into the bronchial tubes, the branching of the bronchial tube slows airflow and causes materials to settle out here. And then when you look at the very tiniest particles, for example, fentanyl freebase or fentanyl citrate or fentanyl oxalate, these are known to produce particles in the 0.05 to 2 micron range. In other words, they can be very small, which means they could be inhaled all the way down into the air sacs of the lungs, where they might dissolve in the moisture here and be passed over into the bloodstream. So how might we then address exposure? Whether people are likely to have exposure as a regular part of their job in healthcare, veterinary care, or whether they are people addressing crime scenes or doing cleanup of workplaces. We like to start always at the top of the hierarchy of controls. The hierarchy is a problem-solving technique, and it's incorporated into many OSHA regulations and NIOSH advisories, among other places. And we believe if we start at the top of the hierarchy, we will be dealing with the most effective method. And if that is not successful, we drop down to the next item in the hierarchy and see what success we might have with that. But keep in mind, even if we draw on many different items from different places on the hierarchy, these can all work together to reduce exposure. So let's start at the top. Is there some way that we could, in fact, physically remove this hazard from the workplace? Well, I would say if you have a workplace where people need to draw on opioids because they're getting injuries or illnesses, then we should be fixing the hazard that causes those problems. So I would like to suggest we look seriously at risk assessment for those types of workplace hazards. But of course, we cannot necessarily remove all of those risks or reduce them all to zero. So let's go down to the next item in the hierarchy. Here is where we might be able to find alternative medications, things that are non-opioids that might address this issue and have people, as a result, have less need to work with opioids in healthcare or veterinary care, or not to find so many of these incidents happening in the community. And if you're interested in alternatives, this is something that will be addressed by one of our speakers on the February 16th webinar. Okay, so let's drop down next on the hierarchy to the engineering controls. Here is where we might have ways to isolate people from the hazard with various types of designs and equipment. Now, of course, for people working in healthcare or veterinary care who are handling opioids as medications, we have such things as biological cabinets, in which people are working in things very much like what you would describe in this instance as a glove box, and so that people can enclose these materials and capture the dust and not have it come out into the workplace proper. And of course, if we're concerned about accidental needle stick injury, we have the issue of sharps containers, and we want to have sharps containers always as close as possible to where we're dealing with patients, or if we are collecting sharps at a crime scene or an overdose site, that we bring the sharps container to the location of the needle so that we can place the sharp directly into the container rather than having to bring the needle to the container. Now, the next item on the hierarchy are what we call administrative controls. People often think of these as including things like training and work practices, but I would also like to remind you that these also involve our decontamination procedures, as well as how we handle the contaminated clothing that might arise from people who are handling these medications, dealing with a forensic examination of illegal sites, or of course, people who become contaminated in some way in addressing a patient. You also have, of course, the people doing site cleanups of various kinds who also will have contaminated clothing. And finally, our last line of defense is personal protective equipment. These are the sorts of things that we put on the individual who is doing this kind of work. So let's unpack some of these items in a bit more detail. Now, when it comes to items on the hierarchy, there is research underway for a potential vaccine for dealing with opioid exposure. And the research in this area has taken what are called haptens, and there were little pieces of drugs such as carfentanil or fentanyl or both, and attach them to a carrier protein and injecting those into the test animals. So far, this immunization has actually worked very well in preventing both the respiratory depression that can cause, of course, arrest of breathing, or bradycardia, the effects on the heart, as well as this vaccine has been shown to prevent the distribution of carfentanil to the brain. These animal studies have been very promising, whether they use opioid haptens alone or in combinations. We have seen this begin to emerge as a viable strategy to prevent opioid toxicity. And we're hoping that these may eventually translate into human studies and eventually perhaps a human vaccine to treat opioid use disorder. But this is in its early stages yet, so we don't have this quite yet. Now, what about air testing around areas where people might have exposure to opioids? What might we set as occupational exposure limits? Well, so far, OSHA has not adopted any limits for opioids, but we have some recommended levels coming out of various places. The U.S. Pharmacopoeia is recommending a 1/10 microgram per cubic meter air concentration as an 8-hour time-weighted average. In other words, someone's exposure could vary throughout their 8-hour shift, so long as the average is not more than a 1/10 microgram per cubic meter, on the idea that the body burden would be at an acceptable level. Now, we also have had pharmaceutical manufacturers come up with limits for their own workplaces where they handle and package these drugs. Mallinckrodt Pharmaceutical Company, for example, uses a 0.7 microgram per cubic meter as an 8-hour time-weighted average. Both the U.S. Pharmacopoeia and Mallinckrodt are recommending also a 2 microgram per cubic meter short-term exposure limit, or STEL. In other words, no 15-minute period in the day could exceed the 2 microgram level, even if you're still meeting that 8-hour time-weighted average of 0.1. Ambrex Pharmaceutical Company is also recommending a limit. They want a very low one here for carfentanil of 0.04 micrograms per cubic meter as an 8-hour time-weighted average. We also have a recommended a level for investigating surface contamination. This one had an unidentified pharmaceutical fentanyl manufacturer recommending it for internal use in their own site. But they are recommending surface contamination not to exceed 1 microgram per 100 square centimeters of surface area. So this is basically what we have to deal with at the moment. Now, when it comes to fentanyl detection standards to protect first responders, these have been issued by the American Society for Testing Materials and were first published in July of 2021, and therefore doing field detection. We have methods for field detection equipment and assays. We have standard guides for how to use this equipment and deal with these assays, as well as standard methods for establishing the performance of these equipment and assays for field detection. So there are indeed standards out there being developed that could be used to protect people in the field. Now, our Department of Homeland Security is recommending a master question list for synthetic opioids so that when people are out in the field doing such things as emergency response or conducting research, that they indeed ask questions about what is going on at this site. These questions get to the information that I'm sharing with you here. They say, for this particular site, what are you dealing with in terms of the chemical and physical properties of that synthetic opioid? In other words, is it a dust, a pill, a rock? Has it been mixed with any adulterants or other types of attenuating agents? Its form, what is its size of the dust that is known for it, anything about it that you could know about that location. You also find that this advisory comes with summaries so that people dealing with various opioids can read quick summaries of what these various drugs, what is known about them and their behavior in the body and so on, what their hazards might be in operational settings, and what would be the appropriate protection measures to prevent worker exposure. And so in unpacking some of this information, there are a few items from the hierarchy of controls that I'll draw to your attention. First of all, administrative controls, recommended work practices for emergency responders. If the exposure is believed to be life-threatening, in other words, the responder is believed to have received a serious exposure here, you, of course, notify dispatch, request EMS and backup, move away from the source and try to remove the exposed individual away from the source. Administer the naloxone, of course, according to your department's guidelines, and of course, perform resuscitation should the person need that. If it's a non-life-threatening exposure, then keep in mind the person exposed should very carefully restrain themselves. Do not touch your eyes, mouth, nose, or skin any further than what's already happened, okay? If you can wash the skin with cool water and soap, if it's available, of course, rinse the eyes out if that's an issue. Do not, however, use hand sanitizers. Alcohol-based hand sanitizers may actually be able to facilitate the movement of the drug through the skin, so we do not want to do that. You want to wash your hands thoroughly and take a look at your department guidelines for how you then doff and dispose of your contaminated clothing. And remember, after this incident, you're going to need to decontaminate surfaces and equipment and use your department-approved cleaning agents and procedures for that. Now, what about personal protective equipment for opioid exposure by first responders? Well, you want to wear a NIOSH-approved P100 respirator. Now, what I'm showing here in the photograph is not recommending any particular manufacturer. I don't endorse manufacturers. Cornell does not do that, but this is a disposable P100. It is also possible to get reusable half-face or full-face respirators with P100 cartridges on them as well. But what we mean by P is that it is oil-proof. It is able to repel substances which are oil-based or oil-soluble. It's 100 because it can filter out or remove by electrostatic action 99.999% of the material, preventing it from getting through the mask to the person wearing it. You want to wear nitrile gloves. These have broad chemical resistance. Nitrile is very good for that. And at the same time, you're avoiding any particular latex allergy problem. For eye protection, best would be unvented goggles. And there are, of course, anti-fogging agents you can always apply to the inside of goggles if they trouble you with fogging, but you want these goggles to be unvented. You do not want any airborne dust to get through vents to your eyes. And of course, preferably to wear a gown covering your clothing as well. Now, in the past, NIOSH, the National Institute for Occupational Safety and Health, part of our Centers for Disease Control, has done investigations of police and firefighters, EMTs, with opioid exposure. And what has been found here is that these people have tended to lack the proper personal protective equipment, or it's been explained to them that it's a voluntary use, so they have not tended to don it, or they've received a lack of training for how to properly don and doff PPE, or to understand exposure scenarios. And it is these gaps which we want to, of course, address. Keep in mind that PPE doffing can be a very good way to get contaminated. And that's a common issue for people dealing with diseases and other types of chemical exposures. Doffing is extremely important so that you do not contaminate yourself. So CDC NIOSH has put out some very nice advisories on this, and I just want to share with you a little bit of that. You do want to wear your personal protective equipment when responding to a site where illicit drugs are suspected to be present. You want to be able to wash your hands with soap and water. Do not touch your eyes, nose, or mouth. Do not use hand sanitizer. We don't want to see hand-to-mouth transfer, so don't eat, drink, smoke. Use the bathroom, of course, can transfer materials on your hands to other parts of the body as well. Keep in mind that exposure can happen. Do not touch or disturb a white powder or liquid. Do not eat, drink, smoke, or use the bathroom while working in that area. And do not use hand sanitizer. It does not remove illicit drugs and may, in fact, increase exposure. You want to wear the proper PPE, have emergency services on standby. Now, what if the site is grossly contaminated? It may be beyond what you can actually handle, in which case it's time to call hazmat or DEA to deal with the site. Keep in mind, you only want to allow properly trained personnel in the appropriate PPE to perform field testing. Now, when you're looking at selecting PPE, for minimal exposure, keep in mind that no amount of suspected illicit drugs are visible. If that is the case, gloves are considered the appropriate choice, and of course, nitrile for its broad chemical resistance. If you suspect moderate exposure, there are small amounts of suspected illicit drugs visible. Then you want to be able to don nitrile gloves, as I was saying earlier, preferably goggles rather than safety glasses, wrist and arm protection, and a disposable respirator. Now, you can wear an N, P, or an R filtering respirator, but you do want to go to the highest level, to the 100 level. Or you can use a reusable elastomeric respirator with the appropriate cartridges at the 100 level. Now, if there is high exposure with large amounts of drugs clearly visible, entry typically is not recommended. You're better to refer this to your hazmat or DEA personnel for cleanup, and they'll come in with much more gear than what we've described here. Keep in mind that you want to be very careful about your PPE and your work practices so that you do not move these drugs elsewhere, particularly take them into your vehicle or take them home with you. Remember, if you're wearing a respirator, you want to be able to remove it, to doff your gloves, to then rinse your hands or any exposed skin. Do not use, of course, hand sanitizer. Doff any work clothing, shower, launder your contaminated clothing, never take these things home with you, and decontaminate or dispose of PPE as per your department's policy. Okay, so thank you. I'm going to stop my share at this point, but if you're interested, of course, would like to contact me otherwise, you can reach me at my email, njb7@cornell.edu, or put my name, of course, into Cornell's website and search on me, and you're bound to find me. I'm going to stop my share here and ask for any questions at this point.
Great. Thank you so much, Nellie. So as we mentioned at the beginning, we have a Q&A at the bottom, or you're welcome to type questions into the chat. One of our participants said, "Thanks so much for putting this together. This approach is sensible when we know or suspect opioids are present. Meanwhile, there's an epidemic of overdose-related fatality among construction workers where we would not expect opioids to be present. What steps in the hierarchy of control can we take to better protect this high-risk population?"
Well, the issue for construction has been typically related to the pain of injury. Construction work carries high risk for physical injury, strains and sprains of all kinds. And as a result, people have often been prescribed opioids and then become addicted as a result. So the issue to me is go back to the work site and fix what you can of the problem. It's a truism in the field of ergonomics that wherever we have lift, lower, or carry, we try to change those to push, pull, or slide using mechanical aids and devices to assist us with work that would be strenuous for the body. But still, it is tough. Construction is indeed a high-risk industry for ergonomics, as well as, of course, for physical trauma. I would like otherwise to refer you to the webinar on February 16th. Here we will have Dr. Singh addressing this issue of treating pain, and there are some things that are non-opioids which might be possibilities here, and he can address that issue for you. And also Dr. Sonnenstahl, who can help you put together a workplace drug recovery program. And in fact, there are other organizations who have been deeply involved in the opioid issue. And I would highly recommend also the AFL-CIO Center to Protect Worker Rights that's been deeply involved in the construction issue and the opioid overlap with construction.
Thank you for the question, and thank you for the answer, Nellie.
Okay, well, if anyone has further concerns, you're welcome to continue to put them into the chat. They will eventually come to me. Or you can email me at njb7@cornell.edu, or put my name, Nellie Brown, into the Cornell website, and you'll connect with me and my publications and further information. So I'm going to turn the program back over to Cricky for our next speaker.
Great.
Thank you
Nellie, there
for
is
giving me
one.
your attention today.
Yeah, there is one additional question. If you're able to answer it. How often is there exposure in the healthcare profession?
Well, where I've seen issues with what are considered hazardous drug exposures in healthcare, it's occurred basically from the arrival of the drug, sometimes arriving at the institution with the packaging broken. It can be as a result, when people first do receive these at their facility. It can occur, of course, in the pharmacy during handling. There can be accidents occurring here. It can be as the drugs are then sent to departments or picked up by the healthcare provider and are taken to the patient use site. There can be exposure there as well. You see similar kinds of things happening as well with veterinary care. And there's always the possibility, of course, with a needle stick injury occurring in healthcare settings of various kinds, which is why we actually, in most any workplace, you'll see the recapping of needles is a forbidden work practice. We put the used needle directly into the sharps container. There is a device which can hold a cap for you, so you can use a one-handed technique, in other words, to push the needle into the cap. Otherwise, we do not want to recap needles. You wouldn't believe the bad hand-eye coordination we have as humans, and we get stuck often by trying to recap needles. So there's all of that. And then there are the occasions outside healthcare where I run into people getting needle sticks because of improperly disposed of syringes. Okay.
Thank you so much, Nellie.
You're most welcome.
At this time, we'll pass it over to Cheryll Moore.
Hi, how are you? Well, it's quite a talk to follow, and I've learned a lot. And this is my role every day of the week. So thank you so much for having me here. My name's Cheryll Moore. I'm with Erie County Health Department. I'm the director of the Office of Harm Reduction and also the Opiate Task Force in Erie County. I'm going to share my screen here, and I do apologize if I'm clunky. We had a little invasion here of a mess on our IT system. So there we go. So we're here to talk today about opioids, which is something I do talk about every day. Is this coming through to you okay?
Right now, we still see the full PowerPoint outside of it.
Interesting. Let's see here. Let me stop the share and try a different one. We were kind of affected here with a little, are we seeing better?
Yep, looks great.
Okay, perfect. All righty. So we're here to talk about opioids overall, the disease of opiate use disorder and substance use disorder. I learned some very interesting things from you, Nellie. Thank you very much. One of the things I do want to talk to you as workplaces, how we can work with our employees. And it's good to hear that the talk will be on the 16th also. Words. The words we are using today are really affecting how people come to us, how they talk to us. If you're going to develop an opioid program at work, a recovery program, this is critical. So just starting with maybe our employee health, employee wellness, learning to talk to people appropriately, learning to use appropriate words. There are many professions that are affected by opioids more than others. We are learning that more and more. People that were prescribed into the disease of opiate use disorder. Today, we do know about 86% of people started with prescription drugs. According to NIH, 75% of them were prescribed by their provider to them. What we know today also is things that we did not. It does not take a long time to develop a disease that you'll have for the rest of your life. 10 to 15% of the population has a predisposition to this disease. We don't know really what the genes are today, but we do know things such as family histories. If we have a family history of alcoholism, we have a family history of clinical obesity, we have a family history of a serious gambling problem, we probably should never take an opioid because that is the track that affects people. And in this individual, it's 3 to 5 days of use to chemically change their body for the rest of their life. So learning together and changing how we work with people is really how we're going to be successful to keep our loved ones with us, healthy and happy. So moving on here, we're going to talk a little bit today, let's see here, about the overdose epidemic in Erie County, New York specifically. I am housed at the Erie County Health Department. We have gathered a lot of data. We've done a lot of interviews. We have learned a lot about the epidemic, and we are learning every day. We are no different than the rest of the country, though, and I want you to be aware of this. We have to take the stigma away here, folks, and that is why I was talking to you about words. It's your neighbor, your child, your coworker. It's not just the celebrities that make the news. We lost Tom Petty in 2017. We lost Prince in 2016, DMX about a year and a half ago. These were all opioid overdoses. We didn't talk about them that way. We talked about cardiac events. We talked about everything. We danced around the subject. But these were very visible public figures. When we come back to our local community, people are ashamed. They're embarrassed. People are judged, and we need to take that away so that people can get the help that they need when they need it, and not on someone else's terms, but on their own terms. This is the task force in Erie County. It has been in place since 2016. We've been working together for all these years now to really try to decrease the death numbers, increase the treatment availability, decrease the initiation of opioid use. There's a lot of moving parts here, and I'm going to talk about some of them today. When we do a training on how to reverse an overdose, we will expand on them. Feel free to ask questions. Feel free to interrupt me. It's okay. I'd rather you didn't forget what you're going to ask. So it's a very unique group. We work with law enforcement, with families and parents who have lost people, community education out of the U.S. Attorney's Office, the doctors, as I call them. When we talk about 86% of people struggling with opioid use disorder today because they started with prescriptions, whether they were prescribed to them or a loving family member, or a friend who shared, a coworker, we need to change that. Changing alternatives to pain management. I was very glad to hear that that's going to be addressed. We've been working very hard on that in Western New York here. There'll be another conference coming up on alternatives. There's many simple things, not starting with the very strongest medications. Let's start lower. Let's look at things that are not medication-based. Let's look at PT, OT, all these different things. Let's avoid the injury to begin with, which is really something we have to look at together. Hospitals and emergency departments are integral into this epidemic. We're very lucky here in Western New York. We've been able to develop a fully virtual program to link people to care. They don't have to leave anywhere. They can do this from their phone, literally. They can call up a doctor. They can have a conversation with them. If medically eligible, they can be put on their first 2 weeks of medication-assisted treatment and then transition to a long-term care provider in that 2 weeks that can walk the journey with them. All these pieces are much different than other places in the country. It's not perfect, but we are on a journey of trying to help people. My office runs harm reduction initiatives. I think we all do things in the world of harm reduction that we don't realize that we do. To put it at its simplest, when you take a pan out of the oven and you use a pot holder, that is harm reduction. We know that pan is very, very hot. If you grabbed it with your hand, you would get burned. So we decrease the harm by using a pot holder. Day-to-day life, wearing a seatbelt. We hope a car crash doesn't happen, but if you have a seatbelt on, the injuries will be less. In the world of substance use disorder, harm reduction involves things like making sure people have Narcan, making sure they have fentanyl test strips so they know what they're getting into, clean syringes, treatment for Hep C, all these things to reduce the harm to the individual. Treatment providers. This is our mental health and substance use treatment providers. This disease has always been housed in this arena. This is not a bad behavior, folks. This is a medical disease when we talk about opiate use disorder. We need to link the two together. We need to have good medical care and good wraparound care. There's no magic here. It's hard work. Recovery is work. But management of any chronic disease is work, and this is no different. So if someone has diabetes, we don't judge them if they don't manage their disease perfectly. In the world of opiate use disorder and substance use disorder, we do. So we need to change how we respond to help people be more successful. Let's talk about this overall. This is not new, and I want to go back a little bit. Looking at it, the CDC has been documenting for a while now and gathering this data so that people can actually look at it. We talked about heroin at the beginning of the epidemic. We talk about heroin deaths, and then we talked about the change to synthetic opioids. On average, and in 2019, 137 Americans were dying every day from an opioid overdose. Today, we're talking close to 200 a day. Those numbers have gone up instead of down. We really are looking at a different drug. We are all talking about fentanyl today. Started out with prescriptions. They decreased, the death numbers decreased because every state in the country really worked on this. We put prescription drug monitoring program in place. In New York State, it is called iStop, went in place in 2014. We saw a difference in the number of deaths that occurred. We saw a difference in the toxicologies from people who had died after that. I will share that with you also. There's 3 waves in this opioid overdose death epidemic, and we have 3 distinct waves. When we talk about wave number 1, that was the prescription opioid overdose deaths. Commonly prescribed opioids, things that we saw daily: OxyContin, oxycodone, Percocet, Lortab, Vicodin, Tylenol 3, you name it. Prescription opioids, that was wave 1. At the same time, heroin has always been around. It has not changed really. In 2010, we saw a little uptick in the use of heroin. We think it is associated with the prescription use because more people were using scripts. They were getting hurt. They were getting prescribed things. They were going on this journey of opiate use disorder, and then they were unable to access the prescriptions, afford whatever it may be, and started to transition to street drugs. Well, then we started to see a third rise, and this is when the synthetic opioids really hit our scene. When I talk about synthetic opioids, we are talking about things, illicit opioids like fentanyl. Fentanyl analogs have drastically changed our community and our landscape. They have killed so many people. This is national data. What is happening here in Erie County really is no different. So we'll look at the time frame, and you can see the uptick here. And this is what I wanted to share with you. The numbers went up regardless. They continue to expand. So we talk about males, we talk about females. The uptick is much higher in males, but when we're talking about occupations, the types of occupations that people were prescribed opioids, very male oriented. Construction, absolutely. First responders, absolutely. People that got hurt. When we talk about the female population, we have a lot of people that worked in the nursing area, in the food service area. People tend to be females. We are seeing there. In our department here, we've done a lot of interviews with people on the street, and we've literally asked them, what happened? How did you get to where you are today? And they've told us their stories, and that is what we share. So we're looking at the different types of drugs involved, and this is something that people have to be very aware of. The best of intentions put prescription drug monitoring programs in place all across the country. Here in New York State, it was put in place in 2014. We saw a huge shift in what the cause of death was for people after that time frame. We really did not understand as a society how sick people were. We were like, oh, they can just stop taking those pills. It's okay. They just started taking them. But it really does not work that way. In that 10 to 15% of the population, there's chemical changes in the body. You're not producing your own opioids. All these factors contributing. The cravings are there. The withdrawals go on. It's a never-ending cyclical process. Additionally, we started to see synthetic opioids in other drugs that we did not expect. This really was a blindsider for folks. It is no different locally than it is nationally. Year to year, we did see a change in our race and ethnicity. This has not changed either. We are talking about the COVID pandemic. We had a huge shift after the COVID pandemic in who was being affected. One of the biggest parts being age, different drugs. We are seeing a shift in race and ethnicity locally also. So across the country, what are we seeing? Post-pandemic, big increase in deaths in our American Indian or Alaska Native population, in our Black population, our Hispanic Latino. It is up in our white population, but no different than in the past. We have had proportionately huge shifts. The numbers went up, but in our communities of color, people of Black and brown skin and Native population, exponentially higher. We're looking at the mortality per 100,000 population, really trying to figure out what was going on pre and post pandemic. In all populations, the number went up. Pre-pandemic, we're out in public. We are talking to people. People that had overdosed perhaps were found by someone. Narcan was administered in public places. Post-pandemic, people are hiding. The drugs are different. It's people we don't anticipate. The ages have changed. We have predisposed ideas of folks. We're like, well, if we have males over 50, they must be having a heart attack. We're in Western New York. We have to think a little bit differently because we are not necessarily seeing that today either. So looking at the national deaths involving cocaine, this is probably the biggest shift we are seeing. I'm going to show you the local data, and this is critical in the workplace. We've talked about medicating with opioids for pain. Well, you medicate with cocaine when you're depressed. You feel better. If you have no energy, you feel better. People are taking cocaine socially also, have done this for many, many, many years, which was all well and good. But the problem is today it's cut with fentanyl. People are not expecting this. They are overdosing and dying. The numbers have gone up exponentially. It's across the country, especially here in Western New York. So let's take a little bit of look here across New York State and see what the difference is. So we're looking at New York State and we're looking at the provisional drug overdose counts. Now, New York State Department of Health manages and monitors all this and puts it on a dashboard. When I say provisional, what we are looking at is what we think it is. We're waiting for the toxicology screens to come back. So a first responder or a police officer is at a scene, they reverse someone or not, or they're transported to a medical examiner's office. They document in their police report what they think they see. We take that and then we correlate it with what actually it is once the toxicology screens are back. We are seeing a shift, but we are also seeing our first responders really understanding what is going on out there. Today, particularly outside of New York City is catching up quickly. What we are seeing here are the death counts that increase exponentially each month. We're getting much better at identifying the scene, identifying what potential drugs would be. Why is this important? Safety of the first responder. We talked about previously, you talked about the PPE, appropriately using it, donning, doffing. People need to know what they're getting into. If they don't believe that that is out there, they don't wear the appropriate PPE. In the Erie County area, I am the one that trains all the first responders. We reinforce this over and over and over. Now, on the other end of the world, we also have to be very careful. We have to be careful that we don't blow out of proportion minor scenes, because we've had that happen also. So, why aren't you going, buddy? These are the different drugs here that we're talking about that we're seeing across New York State. I'm going to show you Erie County specifically. But right now, across New York State, the drugs that have caused deaths have changed. It has been directly associated with our implementation of iStop in 2014, then our isolation during COVID. We saw a whole new population, and it may be somebody that had been successfully managing their disease, but now they were alone. So our drug classes that we saw when we look at this, opioids overall were probably, and that's including everything, the highest cause. We broke it down to see exactly what was causing people's deaths. We all talk about heroin. Heroin is the original opiate. You grow a poppy, you bring it to a lab, you create opium. Been around forever and ever. We read about it in our history books. When we talk about Mesopotamia, we talk about the joy plant, not a new drug. So when we look at the bottom graph and we look at heroin, the blue line, it's kind of flat, has not gone up real high. We continue there. So now let's look at the natural and semi-synthetic drugs. We're talking about things like opium here is what we're talking about. They've taken that poppy in the lab in the first stage of changing. This is well over my head, but that's been around for many, many years also. Methadone. That is an opioid. That is a treatment drug. It is made in a lab. Methadone, the potential for pain management is very good, but treatment, it is very, very effective. Synthetic opioids, excluding methadone, we're seeing that number start to go up again. We are hearing folks talk about ordering drugs online. They are using the dark web. They're just searching on Google, and they're able to purchase things. The problem is these are adulterated medications. We know that they are cut with fentanyl, and we know that people are dying. We'll look at cocaine. Cocaine is going up, continues to go up. We have not seen a change in that. The problem is also that is cut with fentanyl, and then the psychostimulants. So let's talk about the prescription drug issue. And we've had a lot of progress, folks. We are not prescribing as heavily as had been in the past. There are limitations. People are really looking at alternatives. Our dental community, I didn't hear that brought up. That's somewhere where people tend to get a lot of scripts. You have dental surgery. That has completely changed. Very few dentists order opioids today. They're looking for alternatives, things such as anti-inflammatories. They work really well. Things such as acetaminophen. We're looking at heroin users today. What we're learning, we don't have heroin users today because it doesn't exist in our community. We've looked at all different areas. Our prescribing, though, is changing. It has gone down. Are people still getting opioid prescriptions? Absolutely, 100%. We're not perfect, but changes in our medical providers from medical school on, a lot of training is going on. They've actually changed the curriculum in our dental schools. We've been working with our veterinary population just to really educate folks and get them to understand that there are alternatives. We have many practitioners out there that were from the years of pain being classified as one of your vital signs. It's not. Pain's a symptom that something's happening that we need to fix so the pain goes away. So let's talk about Erie County directly. The data I'm going to show you is from the medical examiner's office. If you die in Erie County and we don't know why, an autopsy and toxicology screen will be performed. The autopsy is the physical, toxicology is on the body fluids. That is what takes a very long time for us to get the results. The drugs are changing drastically every day. We work closely with our public safety campus, our law enforcement lab, our medical examiner's office to correlate what we're seeing to really try to identify what is out there. So let's talk about death. This is really sad. These are the latest data I pulled from the medical examiners. 2009, 2010, pre-OxyContin years. 11 through 13, the years that OxyContin was very prevalently prescribed. We prescribed it for everything. You know, you broke your toe, you got OxyContin. We did not understand how sick we're going to be. People that had great prescription plans, union environments, they had very little limitation on how many scripts they could get filled. I mean, they just kept going to the drugstore. And when they ran out of coverage with their prescription plans, well, then they paid cash. Why did they do this? The way opioids work, the more you take, the more receptor sites develop long-term, the more you need. So the doctor shopping occurred because in 10 to 15% of the population, full-blown opiate use disorder had erupted, but people didn't realize. So when they stopped taking their opioids, they were sick. They were hugging the toilet. They were throwing up. They had diarrhea. They hurt all over. Didn't really know what was going on. What I'm describing to you is withdrawal. By taking more opioids, that would go away. So we looked at that and people doctor shopped. Well, then in 2014, you see 127 deaths. That is the year New York State put a law in place called iStop. It is a prescription drug monitoring program. It is the checks and balances. So since then, if you go to your doctor and you want a prescription opioid, they're looking you up in a web-based system. We no longer have paper prescribing. That took the whole piece of diversion out of the way. You couldn't steal a prescription pad. All these things occurred. This was with the best of intentions, folks. We didn't understand how sick people were. You're probably seeing it in your workplaces today without even realizing, and this is where the journey began. So people were able to self-medicate until they couldn't get them anymore. Then they started purchasing things on the street. We transitioned to heroin, the original opiate, but soon learned that was not a strong enough medication. People had way too many receptor sites. We went up to 301 deaths in 2016. The task force came together. We changed a lot of stuff. Got down to 156 deaths, and then COVID hit. The isolation of COVID exacerbated this epidemic, the same as I stopped did. People being alone. We have to be very careful, folks, as a society. We need to not judge, and we also need to check on our fellow person. If you think something is wrong, please go knock on that door and find out what's going on. Traditionally, we find people in public places when they overdose, including work sites, outhouses at lunchtime. People are sick. They do not want to die. No one wants to die, and they want to be somewhere where someone can help them. You have to understand people are scared, particularly when they're purchasing substances on the street. They have no idea what they're buying. And if they take something too strong and stop breathing and no one's there, they will die. So during COVID, we saw a lot of that. People were in single family homes. They were home alone. There was no checkup because people were laid off. Nobody called to find out why you didn't go to work, and then we didn't find you for a few days. We did get up to 286 deaths in 2021. I just checked the Emmys this morning. We have 265 confirmed deaths for 2022, and we still have 52 pending cases. That means we're waiting the results of the toxicology screens. We are seeing a different individual. We are seeing different drugs. There's all these changing factors. We update this as quickly as possible so that people can understand what is happening. We have not confirmed any 2023s yet. We're still working on 22. Very male disease. It is 3-to-1 male, the deaths that we see. And I have years and years and years of data here to support this. If you ever need data, feel free to reach out to us. It's sometimes a picture says 1,000 words when you're talking to people, and they'll be like, oh gosh, that's true. Race and ethnicity changing. I showed you the national data. Here is our local data. This disease is affecting more people of Black and brown skin. Now, I want to caution you, in 2021, we started to look at that quickly, and we needed some more information. That is not complete information in that final column. The second column is, it shouldn't say 2021, it should say 2022, my apologies. That's when we had 178 completed and 106 pending. As you can see, our numbers are up much higher now. We are trending about 24% Black or African American right now. Our Native American numbers are going up once again. So we really need to take a look at this. We need to talk to our community members. We need to ask, what on earth is going on and how can we help? And what do you think would make it better? Talk to your workplaces, talk to everyone. Another thing we're seeing a big change in, and this will affect workplaces, the ages. We all talk about children in this disease. This is not a children's disease. As you can see at the bottom, 20 to 29-year-olds was our biggest chunk of people that for a long time we were losing, and 30 to 39, no longer true. Who we are losing today are people in their 40s, 50s, and 60s, people that we don't expect.
And Cheryl, really quick, there's a question in the chat.
Sure.
Do you ask occupation information for drug deaths?
Actually, yes, we do when we do the reviews for the Opioid Fatality Review Board, yes. Not every person, that we interview, but we do that, and I can pull that data together. That is something that we have looked at. Physical professions, people that have been hurt, have been maintaining on their own for many, many years, and then they've been able to do it quietly, and then their access to prescriptions were no longer there. So yes, I'm happy to share that. I can get it together if you want something specific. Race and ethnicity, as I said, is changing. I don't know what happened here. But what we are seeing, the green line is our Hispanic population and the purple is our Native population. They are going up, both of them. Our white population is going down. Our ages. This is the big one, folks, and I want you to be aware of this when you talk about your employees. We always look at the young people. This is not a young person's disease. You can see it here in the bar chart. Under 20, our deaths are minimal. I mean, they are minimal. Our biggest increasing areas are the 40 and over. We are seeing huge amounts of deaths increase in that area proportionately to our population. Different drugs, different folks. Not real sure. We're going to be doing interviews with folks. And honestly, that's what we ask. What happened? Where did you initiate? How can we help? Here's another way to look at the age, and I really want to emphasize with you, we all looked at the beginning of the epidemic. We were looking at the younger component of our population. As you can see, though, that blue dotted line, the 20 to 29-year-olds, that has gone down significantly. The under 20s, the purple, gone down significantly. What goes up? Every other age group. 30 to 39 is decreasing also. But that 40 to 49 has popped up. Then we talk about 50 to 59 and 60 plus. Different individual we're seeing today, much different individual. Residents at time of death. We've gone through 20, we're compiling 22 right now, which is why I'm not sharing it with you. I don't want to give you bad information, but it looks very much like 21. About a third to a half of the people that have died are in the city of Buffalo. They are residents at time of death, city of Buffalo. The other 2/3 everywhere. There's not a town or a village where people are not affected. Within the city of Buffalo, it was different than we have anticipated. Most of the deaths occur in the North Buffalo and South Buffalo areas. Different than we thought. Historically, opioid use west side of Buffalo has been, people still do purchase when I've learned working with law enforcement, but that is really not the area. Different individual once again. What did people die from? Here's the $1 million question. Well, the beginning of the epidemic, the year we put the law in place where we limited access to prescription drugs, about half of our deaths were attributed to prescription opioids. That's the purple. We just lumped them all together. Most popular around here, things like OxyContin, oxycodone, Vicodin, Percocet. So people like fentanyl. Prescription fentanyl is in that mix, the other opioid. Fentanyl related that you're seeing here, we started to see a powder in our community, and these were analogs of the legal drug fentanyl. They basically took that fentanyl molecule and they added something, whether it was a butyryl chain, a 3-methyl chain, a acetyl chain, an acryl chain, and they modified that drug just a little bit that the FDA and the DEA has approved to be different, a little bit stronger, we're learning. And also, unless it's in an area where law enforcement works together, generally not chargeable if someone is found with it. 50 to 100 times stronger than the heroin on the street. The fentanyl we're talking about, it's powder. The equivalent of 3 to 5 grains of salt is all it takes to kill a non-opioid user. So 2014, best of intentions, we limited prescription drugs. And this is what the death breakdown was. Let me jump to 2022. Today, we no longer have very few prescription deaths. There's about 9% of them. We do not have heroin. That's minimal. What kills everybody in our community is fentanyl. This is from our toxicologies. Fentanyl is not the only drug in there, though I want to share with you. Polysubstance is prevalent, and the fentanyl is in things that we don't expect anymore. These, for your workplaces, are the types of drugs that you need to be aware of. When we talk about fentanyl, at the top left with that piece of luggage, those are kilos of fentanyl. They were found at a domestic incident in South Buffalo in 2014. This is how it comes in packaged. When they brought it to the lab, it was the first experience in the whole country with butyryl fentanyl. They had no idea what it was. It wasn't testing. They worked closely with their national DEA partners. They identified new drugs. The next picture over in the middle, those are bags. They're glassine envelopes, but if someone is buying illicit opioids in a powder format, that's what they come in. They are marked by the drug dealer. So if you see them in your workplaces, in your bathroom, whatever they are, you'll know what it is. Kind of looks like wax paper almost. If you've ever baked and used parchment paper, that kind of feels like the product. They're marked by a dealer because this is a business. They're going to say, I got the good stuff, you got the bad stuff. To the left, those green things rubber banded together. That's 10 of those bags rubber banded together. This is a business once again, you get a better deal. That sandy looking stuff, that's butyryl fentanyl. That's pure butyryl fentanyl. If you saw 3 to 5 grains of that on a table, it would be pretty amazing, but that is all it takes to kill a non-opioid user. Today, people that have been struggling with opiate use disorder, they are taking that to not be sick, and they're taking it many, many times a day. Now I'm going to address the pretty brightly colored pictures. The one at the top that looks like brightly colored marshmallows. The DEA put that out at Halloween time, and said, everybody watch your kids' candy. That is from the West Coast. We don't have that here. I'm going to put it out there. The ones on the bottom, we do not have the Skittles here either. They did find some in New York City, but we don't have them in Western New York. I checked with the lab. We have something that looks similar, but they're blue. And what they are, they look like a Percocet. They are bought illicitly. They are not perks. They are nothing but fentanyl. But I want to address what isn't here. We can't provide false information. There is too much going on out there. And I'll tell you I have a team of peers, people in lived recovery that work with us here. And I want you to not worry about your children. What our peers have said, if I was in active drug use, there is no way I am giving that to your children. It costs money. So we have to take that. We have to take all the fallacies out of this and get facts out in the community. These are prescription opioids that are still out there. Other things that you see up there, that bottle at the top, that is methadone. Methadone is a treatment drug. If you're talking about treatment of somebody, and you may see these in the workplace, if you have a take-home dose, people have to return those bottles to the treatment agency so that they can validate they actually took it. You see Suboxone there. That is another treatment drug. It is a strip. Very simple drug to take. That one's purchased at a drugstore. So let's talk about these deaths overall. This is a different way to look at that transition here. And that's why I wanted to show you what the drugs actually were. So in 2014, best of intentions, we put that prescription law in place, and that's that purple line. The numbers went down for prescription drug deaths, but what did go up exponentially is fentanyl. Heroin went down. We've learned because it's not a really strong drug. It does not meet the need to take the sick away for people. So fentanyls have taken over our community. And this is probably one of the biggest ones I want you to be aware of in your workplace. More than 50% of our deaths in 2022, and we've actually compiled more numbers than this, it's about 56% of our deaths are attributed to a mixture of cocaine and fentanyl. This is a different person. This is not the person that was on prescription drugs and, now they're buying on the street because they don't understand why they're not, they're sick when they don't take them. They're no longer medicating for pain. They're medicating for withdrawal with prescriptions. This is a lot of times social. It's a lot of times a way to get through the day, give you a lot of energy. It is a stimulant. When people do a line, take a bump, however they're doing it, it's cut with fentanyl today and they're dying. We're seeing this increase more and more. We've correlated it to an older person. Cocaine is not a cheap drug. We will put the charts out as soon as our analyst is done looking at them 6 ways from Sunday. So we're not looking at erroneous information, but it appears to be somebody a little bit older. There does not appear to be a race or ethnicity differentiation. It appears to be somebody that's got a little bit of money. We've talked to people that we work with in our harm reduction world about this, and they're like, yeah, it's expensive stuff. So it kind of makes sense. The other thing I want you to be aware of is the fact that fentanyl today is also in methamphetamine. So someone that was on a stimulant, maybe they were being treated for ADHD, they lost their insurance and they decide to self-medicate at work. And they bought something on the street to self-medicate, which would be like methamphetamine, and they stopped breathing because it was contaminated with fentanyl. All of these things are poisonings. People are being poisoned with this illicit fentanyl. And we have to be very careful and aware of what's out there. So how has this epidemic affected the workforce? We looked at this county by county. This isn't new, folks. I want to share this with you. And that's why I pulled this clip. This is from 2017, and we're still talking about it. We are still talking about it. We need to take action. We need to be supportive. We need to get people where they need to be on their journey of recovery, whether it is through the workplace, through outside the workplace, wherever it may be. So recent research, it's staggering. We looked at the work of Ann Case and Angus Deaton at Princeton. They continue to look at this. The Council on Economic Advisors in 2018 said the costs are, oh my gosh, astronomical, completely astronomical. You have to understand that nobody woke up one day and said, I think I'm going to be a drug addict. I'm going to do all the things that everybody's told me not to do. You got to realize this is a disease. People don't feel good. and they will do anything to feel good. But at the same time, we don't take into consideration how it's affecting everything else in society. Because when you're struggling with opiate use disorder, the only thing that you care about if you're not treated is feeling okay. So many workplace resources are out there. The CDC has put many together, and I'm sure there's more. The link is here. We'll be happy to share that, but it hasn't ended. So what you're doing here is critical. Addressing things, bridging occupational safety is critical. Opening up that conversation so people can come to your workplace wellness, so you can have a recovery group. You can do whatever it is that you need to do to support your employees, keep them with us, and have a productive society. What do you look for as an employer? People always ask, like, what do I look for? How do I know something's wrong? Well, we look at a lot of unexplained lateness, missing Mondays and Fridays. Weekends are tough, and you feel really bad. You made it to lunch and all of a sudden your employee's missing. Opioids don't stay in your system a real long time unless you have an extended release patch, like a fentanyl patch, which lasts a few days. So maybe someone was able to get some medication to get in their system, so they weren't feeling bad, throwing up, having diarrhea, but by lunchtime it's wearing off. They don't feel good and they have no more, so they'll leave. Leaving early often. Cyclical illness patterns. If someone is still getting prescriptions and they're taking them, but they aren't sharing with their provider that's not strong enough, and they have a month's worth, but by the second week in, they've taken them all. Now they get them to work the third week. They're not real productive because they're not feeling real good. They're starting to get achy. They're starting to get the runny nose. By the fourth week, they can't really function. They're home in bed. So all these factors, cyclical, it's worth a conversation, being gentle, being respectful. Falling asleep on the job. There are people that work, a whole lot. Maybe they have a newborn. You got to take that. But unexplained falling asleep on the job, no. Being overly alert with the stimulants. We're talking about the methamphetamine. We're talking about cocaine, overly alert. Unexplained mistakes. You have an employee that was amazing. They're doing great things. And all of a sudden they got mistakes all the time. Have a conversation. And you hear me saying, have a conversation. That's what we have to do. We cannot point fingers because you will shut someone down. What else can you do? Keep that lines of communication open, folks. Talk to people. Work with your insurers to include paid management alternatives. One of the things that we have learned over time, working with many workplaces, many of these alternatives are not covered. So if you're in negotiations for your new insurance plan, try to get these things covered. They are great alternatives for pain management, which can stop that entrance in that journey of opiate use disorder. Encourage the utilization of good EAP resources. Know what your resources are also. Provide education in your break rooms where people can pick it up on their own, where someone isn't looking at them. Do things such as toilet tips. That's where people can look at things. They don't have to have a coworker know what they're doing. There's so much stigma around this disease. It's really tough. Share the addiction hotline number that is out there. We are there. It's 831-7007. It's a 24/7 number. They can refer you to the right places, including my office. Narcan training for safety teams and your general employee population. People tend to go to say, I've been to a lot of the big employers. I've been to DuPont. I've been at Dunlop. I've been at at Ford. They tend to bring in their safety teams, and that misses the boat. Safety teams is very important. Please offer this to your general population also. I'll tell you, Praxair, an amazing organization. We've done this with their general population. I've gotten feedback over the years from them about people that we don't understand and we don't expect because we have this preconceived idea. Provide Narcan wall units at worksite locations. I'm going to show you a slide of them here so that people can just take this life-saving medication. We'll always provide it to you. Employee seminars. Educate your human resources personnel, please. They're the front line that somebody probably will go to, and they need to know the appropriate referrals. They need to know how to have a conversation with someone. These are needle and drug kiosks. They are all over Western New York. If people are on opioid medications or any medications, please tell them to get rid of them in these kiosks, okay? Don't save them for a rainy day. If you have somebody struggling and they come to visit you, those medications will be gone. They can't leave them there. They physically can't. They're so sick. Do not flush them. Do not get them in our water table. They're burned at Covanta Energy here, and at least, you know, they're not getting in our fish. An environmental study, it was released about 2 years ago. Lake Erie's fish have detectable amounts of antidepressants, and we don't want to see that anymore. Not a good thing. When we go back to talking about isolation, this information should be in your break rooms for employees also. There's a program called Never Use Alone. It was put in place during COVID, well, actually expanded. It had been put in place for a long time. It is in the New York, New Jersey area. It is a peer-run program. If someone is going to use something, anything, they call a number, go on Facebook, go on the, I don't care how they contact the operator. They have a conversation. They agree to respond in a set amount of time. The two people agree. If not, that operator will send EMS to save someone. This is a disease of shame and embarrassment. Nobody wants to be sick. They don't want to be preached at. They don't want to be judged, and they don't want to die, I'm going to tell you. So this is a way to get somebody on that journey. And they can also have a conversation with someone in lived recovery, which may start them on their journey of recovery. These are the wall units I talked to you about. They're available for free. They come from the county health department. We will give you the unit. We will give you all the Narcan to put in them. You just need to reach out to us for that. I'm happy to get them out to you. You can pick them up. We can mail them out to you. We just ask that you monitor them and you refill them with Narcan. We want the public to take them. They can be outside, they can be inside. They are not wired, they are not alarmed. It's really just about having that life-saving unit there and that tool there in people's hands. This is text for Narcan. These are all responses you can put out in your workplace. This also comes to my office. What I tell people, and you can do it if you have maybe a rotating screen, it can be up there, we can share this. And people simply scan that little QR code. They text our office, they ask for a Narcan kit, and we give them that. We give them fentanyl test strips if they would like that. We have not even talked about those. Those are not for first responders. They are not for people to test people. They're for an individual to test a product before they use it. We don't want people to go into things blind, particularly people that think they're getting a stimulant today. They have no idea. So it's free. There's no questions asked. You will get connection to care information. What I tell people here is, you know, scan this, save it in your contacts. Gosh, you never know when you're going to need Narcan. Send us a text. We'll get it out to you ASAP. For your workplaces, we offer curbside care. We do this regularly around the community. If you want to do an employee health day, an education day, we're happy to come out, talk to people about health and harm reduction, about treatment. We can link people. You can bring a team of peers there. If you have people struggling and they're embarrassed, ashamed, maybe they don't want to go to employee health, but they could talk to a peer from the county, we get them linked to treatment on the spot. So all these things happen. We're happy to help. We're happy to partner, to support. That is our role. Messaging in the community. And this is something you have to realize at your workplaces. Narcan's first aid, folks. It's simply first aid. You're never going to harm somebody. It should be available to your safety team, to your employees, whoever it may be. If people have children at home, they should have it at home. Everyone should have it in your first aid kit. Very benign drug. You're not going to harm somebody, but you may save a life, which is amazing. So today, this is what we're seeing. We have to share this message and we have to be honest and open. We're losing way too many people to dance around the subject. Forums like today are critical, absolutely critical. You'll see more messaging go out like this. This comes out of our office. We are happy to share this messaging for all of your workplaces. If there are places you can post it, get the open, honest message out there. Methamphetamine. And on the positive note, I want to share with you, recovery is possible, folks. Don't ever give up. This is our lead peer here at work, Antonio. I have had the privilege of working with Antonio for more than 20 years. He has 23 years in recovery this past January. Was it a perfect journey? No, it's probably a weavy road. But recovery is possible. And this is per Antonio, life, family, and him. That's the important reason. You will have many employees that are struggling in different places, but they're working their recovery. If they have a relapse and they continue to do their job and they're not using illegal medications, that's just part of the disease. Sometimes they need to get their medications adjusted. Maybe they need to see a different provider, a different counselor, they're not clicking, whatever it may be. But relapse is part of the disease of opiate use disorder and substance use disorder. We really need to do is support that individual and get them to the correct place where they need to be. If there's a problem, we're happy to help you. We're happy to give you any resources that need be. Here is my contact information, and I'm happy to answer any questions.
Thank you so much, Cheryl. I just first wanted to say that there's a lot of appreciation for both yours and Nellie's information from folks in the chat. So folks are really appreciative of this information. So there's sort of a series of questions. You had mentioned training for employers, and so I'll group these all together and I'm happy to jump back to them. But do you work with employers on harm reduction training to prevent overdose? And in that regard, do you push the don't blame the victim approach?
The don't blame the victim approach. That would be harm. Yeah, that is harm reduction. It's not an approach of don't blame. They don't mean it. I'll be honest with you. They don't mean it.
Yeah.
They don't know what they're taking as part of the problem. And I think you really have to be aware of that, particularly people that are self-medicating. They may not have enough in their prescription. If we do, and I appreciate you asking that, if you point a finger at somebody, they will shut down and we will never be able to work with them. We've learned this. I'll share openly. I've lived this more than 30 years in my family. I've lost a sister. I've worked this for many, many years. Experience being in our 30-year journey, finger pointing, not so good. Asking a question, offering to help, much better.
Thank you. And sort of related to this training, logistically, how quickly or how far in advance does an employer need to reach out if they want the Department of Health to present to their employees? And can you, at the Department of Health, tailor it to the workplace or to those employees?
Yeah. I actually definitely tailor it to the different employees. What schools here is a little bit different than a construction worker here is. It's a little bit different. We all have different experiences, and absolutely. I can usually get out to you within a week.
Great.
Yeah.
Are standing orders required for businesses to have Narcan on hand outside of training and inspecting the wall cabinets? What else is required for a business to include this safely and appropriately?
Standing orders we ask that in EMS provision areas, in areas that have medical providers. There's different criteria. If you're a school system, schools have different rules. We do standing orders with them because they fall under state education. EMS criteria, I would have an EMS training captain, and really that individual, why a standing order would be in place so that they can relay the information to more of their colleagues. So you can, if you want to go further, but it is not necessary, no. And as far as having a wall unit, all we would ask you to do is monitor it, send us a text when you need more stuff, and we'll send it to you and just refill it. That's all. That's literally all we would ask. If you would like to do more, we're welcome that. We have actually just gotten a new unit in, but I don't even have one put together yet. It's a freestanding unit, and this would probably be good for big employers. Very much like those old, you get like the free newspapers in, those plastic blow mold units. We have purple ones that have Narcan in them. They have sharps containers for people that may need them, whatever tools that they need for harm reduction. That may be an option for an employer too, if they don't want to do all units.
Great. Are there examples, and I don't know how much you're able to share, are there examples locally of programs where employers have really done well supporting their employees in this? I know you mentioned a couple. If you could give a little bit of flavor to some of those.
Sure. I've been working closely with Ford and UAW for about 5-6 years now, actually. We've done a lot of training with employees. We've trained the safety team. They have wall units. They have a support group. They have treatment available right in the plant. Really amazing. Absolutely. I can't say enough, like holy macaroni. We've been working with Dunlop. All the safety team has been trained. We have a referral system. I've been at Fresenius Kabi many, many times where fentanyl is actually produced. We looked at a different mechanism there. We were looking at safety of employees and how people were handling things. And then with the knowledge that people may have a struggle that they weren't talking to their coworkers about. So it opened the door for employees to reach out for treatment. Sometimes, and I just want you to be aware, people do not want to go to their HR or to their personnel because they're like, oh no, they're going to judge me, to get linked to care. If you do have employees, you're happy to refer them to our team here at the county. We will get them linked up to care, put that out there, and we will refer them back to your group. But any way to get that person linked to appropriate care so that we don't lose them.
Thank you. This might be very specific information, but do you all have information about how frequently people use those kits?
Oh, yeah. Yeah, I do. I can share that also. We do track Narcan uses. In Erie County, all 26 police departments carry Narcan. We have charged them with writing the report at a scene. So they go to all the scenes. That's why we went with that. They tend to be the first ones there. They document how many kits were used, whether it is by somebody on the scene before they get there, how many they use, how many that are used by first responders. Now, I will share with you, we will never know the total amount because as many people reverse to literally start breathing, get up and walk away. Maybe a friend or family member reversed them, and we're never going to know about those.
Great. So those were all the questions that we had right now, but we'll give folks another minute in case they're continuing to type for the question and answer.
For workplace specific, I will share with you, I generally will update. I'd like to know where the workplaces are. I'll bring you the data that's specific to your area so that people can kind of be like, I tend to get, well, not here. No, it's here, I promise you.
Great. And just to clarify, to get the kit, you don't need to do a training?
No, you will get a, with the kit, just to let you know, you will get a card that has a little video on it that is a training video. So there's a little QR code here. I don't know if you can see it up here, but this is a training video. It's about 10 minutes long, shows you exactly how to use the Narcan. Now, certain occupations, I want you to be aware, are required to do this by the state. I've learned more and more. First responders, the schools have to have it. It is a 2-year training. If we come out, you will get the 2-year New York State certification. It is good for 2 years. Law enforcement, security, they're starting to require it in more places. So it is the New York State. If you come to us, you will be good. Like I say, if you come out and they're doing, I've had a bunch of fire halls recently who haven't had their updates, and I learned State Fire was in doing inspections, so we've been back out.
Great, thank you.
Mm-hmm.
Well, I think those were all the questions that we had from participants so far. But like Cheryl mentioned, like Nellie mentioned, we have their contact information that will provide all of the attendees and folks who have registered. And we'll be sending out these resources and the recording of this program to everyone who attended. Just a reminder for everybody. So this was the first in a 3-part series. The next program will be Thursday, February 16th from 10 to 12 p.m. And the link to that registration will be again in the follow-up email that we'll provide. And that, as Nellie, as Cheryl mentioned, we'll really be talking about opioids and workers' comp, maybe some alternative options for folks, workplace policies on prescription drug use, opioids, and mental health concerns. I know we sort of skimmed the surface today, having the conversation about how the pandemic really exacerbated some of these challenges. And so we'll dig a little bit more into that. And then finally, as was mentioned, we're actually going to have a Narcan training on Thursday, March 2nd. So that'll be in person at UAW Local 9 in Williamsville. And I'll follow up in the email for that registration as well. But if you do have any questions, my information, Cheryl's information, Nellie's information, and others will be in the follow-up email. I'll just check the chat. Will these slides be provided? I believe they will be. So Cheryl and Nellie, just wanted to confirm with you both.
Absolutely. I'll send them to you.
Great.
Yeah, absolutely.
Generally, my work is considered intellectual property of Cornell University, so I would ask that people view the recording. But I do not typically share the slides.
Okay, thank you. So we'll share half of the presentation, and then others will be able to reference the recording for the first half. All right, so with that, we just want to thank you again for coming to talk about this very important issue, and we really encourage you to continue this conversation and to figure out, are there opportunities within your workplace where you can integrate some of the suggestions that were made available today. So thank you for attending, and we look forward to seeing you at the next workshop.
Thank you for hosting.